it becomes almost a regular feature with increasing risk of distant metastasis and increasing mortality. Tell me how many of you have ever seen an anaplastic carcinoma which was 1 centimeter in diameter and intrathyroidal. It simply doesn't exist. So as it gets worse and worse histologically, clinically, also it becomes bigger and bigger with gross extrathyroid extension, increased risk of distant metastasis, and increased mortality. And this is very readily clinically seen. Now, if you look at it from a different perspective, as I say, a great majority of patients will remain at this stage and will be highly curable with little impact on mortality. It is only this group of patients where we can make the difference with aggressive therapy today. We have very little to offer for anaplastic carcinoma unless Dr. Chen finds a viral agent which will kill anaplastic cancer in the human, but we have no active therapeutic regimen for anaplastic carcinoma. These we can easily cure, and it is this group of patients which is where we need to spend more time, effort, money and resources if we are going to make the difference in the spectrum of outcome of thyroid cancer. As I said a moment ago, great majority of patients are cured following their initial surgery alone. Keep in mind, thyroid cancer is a surgical disease, and I am willing to debate that if somebody wishes to. Approximately 10% of patients following initial surgery will develop recurrent disease either in the thyroid bed or in the regional lymph nodes, will still be amenable to therapy and can still be cured. Mortality actually in the differentiated carcinoma group is well below 2%. If we generally follow the philosophy promulgated by many institutions, individuals, and therapeutic guidelines, which recommend that the patients with differentiated carcinoma undergo total or near total thyroidectomy, followed by radioiodine ablation, followed by radioiodine therapy, and follow-up of these patients with thyroglobulin, annual RAI scan, and ultrasound, we will be grossly over-treating a whole group, a large group of patients without any significant positive impact on outcome. Some patients might benefit from this particular treatment strategy, but in some patients, this treatment strategy will have no impact, and those are the ones with poorly differentiated carcinoma. So we need to think back, put our thinking cap, and see how our improved understanding of the biology of this cancer allows us to modify treatment strategies and develop treatment algorithms appropriate to the disease process. It is now 20 plus years, nearly 25 years, that we have come to appreciate that what matters in thyroid cancer outcomes is not what we do, but what the biology of the tumor does. Not a single institutional or cooperative group report has shown that therapy is an independent prognostic factor in differentiated carcinoma of the thyroid gland. What matters in thyroid cancer, and I will use the word papillary carcinoma because that's the most common variant, is the prognostic factors repeatedly shown in numerous institutional reports to be the same. These are at least 5 examples. There are, if you look the literature carefully, there are at least 17 prognostic criteria publicized or published in the literature. I have taken some common ones, 2 from the Mayo Clinic, 1 from the Clinic, from Karolinska, and from Memorial as examples, each of which indicate that patient's age, tumor size, extrathyroid extension, tumor histology, and the presence of distant metastases are independent parameters of prognosis on multivariate analysis. In fact, this is the only human cancer where patient's age is a significant factor impacting upon prognosis. So let's see how effective or how strong is the impact of each of these factors. I apologize for this slide, these small slides, 4 slides crammed into one. and just because of constraints on time. But the point I make is that patient's age depicted here shows that patients under the age of 45, so-called young patients, have an outstanding prognosis simply by the fact that they are young. They have the same tumor, same size, same other parameters. And the results I share with you are those of a consecutive series of patients treated in my department with a minimum 20-year follow-up. So here's the, keep this in mind, 5-year follow-up means very little in thyroid cancer. These are 20-year numbers. At 20 years, younger patients enjoy a 99% disease-free survivorship compared to only 70% in the older patients. Now, there is nothing magic about 45 age. It's a slope. So 40 is younger than 50, and 50 is younger than 60, and so on and so forth. You have to draw a line someplace, and the AJCC chose to use 45 as a dividing line between the young and the older group. Females in general do slightly better than men, and histology, as we rightfully saw, well-differentiated tumors do much better than those which are less well-differentiated. Tumor size is an important factor. Smaller tumors, less than 4 centimeters in diameter, enjoy a 91% 20-year survivorship compared to only 57%